AJCC mentions that you can use that terminology, but in other areas it uses well-differentiated appendiceal adenocarcinoma. And PSGI terms used previously include low-grade mucinous carcinoma peritonei, so that uses the term carcinoma, and disseminated peritoneal adenomucinosis, where the term carcinoma is absent. Lesions with high-grade cytology, which typically have infiltrate invasion but do not have signet ring cells, are called mucinous adenocarcinoma, moderately differentiated, or in the PSOGI system, they're called either high-grade mucinous carcinoma peritonei or peritoneal mucinous carcinomatosis, PMCA. And then those that have signet ring cells can be called, depending upon the percentage of signet ring cells, mucinous adenocarcinoma with signet ring cells or mucinous signet ring cell carcinoma. And the term with signet ring cells is then tagged on to the PSOGI terminology. So this is kind of your whirlwind review of the terminology used for the appendix. And going forward, I will be primarily using the WHO terminology. As you can imagine, it's difficult for trainees to learn this terminology, given that there's multiple different terms that they could be reading about. And it's helpful, we thought, to develop an algorithmic approach to looking at these neoplasms. And as we go through this one, you will probably note that there are some oversimplifications, and there are also some mimics that are left out of this algorithm. And in the second part of my section on neoplasms, I'll talk about some of these mimics and how you could fit them into the teaching algorithm. But to start by going through the algorithm, we start at the top, where on the left side I have primary appendiceal tumors, and on the right side I have peritoneal tumors, so clinical pseudomyxoma peritonei. Let's start with our primary tumors. Our first branch point in the algorithm, which is a little bit oversimplified, involves assessing whether or not neoplastic epithelium is present. And technically at this branch point, you should also be assessing architecture. Specifically, if you see architectural features of lamin, you do want to make sure that you're examining this very carefully to rule out a lamin, not just always a mucocele. But in any case, let's move to the side of the algorithm where neoplastic epithelium is absent. So as I mentioned, yeah, this is horrible. I'm going to start over. If you get tired of this, you can just tell me to go away. Yep. Hi everyone, my name's and I'm a GI pathology fellow at Johns Hopkins. Today I'm going to be talking about pathology of the appendix. I'll begin by talking about mucinous neoplasms with a brief review of the nomenclature, and then I'll be discussing an algorithm that I developed along with some of our faculty members here for teaching. And then I'll be going over some histologic mimics of mucinous neoplasms. For the second half of my talk, I'll discuss some non-neoplastic entities, including the inverted appendix and granulomatous appendicitis, and I'll conclude with some remarks about whether or not the appendix is truly vestigial. Many of the photos, actually the majority of them, used in this presentation are going to be incorporated into an app that I developed along with my co-authors here. I otherwise have no relevant financial disclosures. Sorry, one slide too much. So let's start with our Appendiceal Mucinous Neoplasms. As you're probably all aware, there's a long history of confusing nomenclature for appendiceal neoplasms. Pathologists have used various different terms historically, and this is particularly true of disseminated peritoneal disease. To address this problem, the Peritoneal Surface Oncology Group International, or PSOGI, which consists of pathologists, surgeons, and oncologists, developed a three-tiered consensus classification system. And this system is evidence-based, and it has been adopted into the AJCC 8th edition and WHO 5th edition now. So grade 1 corresponds to well-differentiated, grade 2 to moderately, and grade 3 to poorly differentiated, and histologic criteria for each category is outlined in WHO. So to briefly review the nomenclature of primary appendiceal tumors, those that have low-grade cytology and lack infiltrative invasion are referred to as low-grade appendiceal mucinous neoplasm or lamin. Those that have high-grade cytology and no infiltrative invasion, which is relatively rare, are called high-grade appendiceal mucinous neoplasm or Hammond. Those that have infiltrative invasion but lack signet ring cells are called mucinous adenocarcinoma grade 2. and those that have a prominent signet ring, or that have a significant signet ring cell component are called mucinous adenocarcinoma signet ring cells, or if they have more than 50% signet ring cells, they can be called a mucinous signet ring cell carcinoma. Moving on to appendiceal mucinous neoplasms that are involved in the peritoneum, here we can see a comparison of the WHO and AJCC terms and the PSO-GI terms. So tumors with low-grade cytology that have a pushing border as opposed to true infiltrating invasion can be called low-grade appendiceal mucinous neoplasm or low-grade mucinous neoplasm involving the peritoneum. The AJCC 8th edition also refers to these as well-differentiated appendiceal adenocarcinoma. So there's some controversy as to whether these are called carcinoma or not, and I'll discuss that a bit more later. The corresponding PSO-GI terminology for these is low-grade mucinous carcinoma peritoneum or disseminated peritoneal adenomucinosis (PAM). Tumors that have high-grade cytology and typically have infiltrative invasion but lack signet ring cells are called mucinous adenocarcinoma grade 2, or in the PSO-GI system, high-grade mucinous carcinoma peritonei or peritoneal mucinous carcinomatosis (PMCA). And then those with signet ring cells are called, we tag on the term with signet ring cells if it's less than 50%, or you can call it a mucinous signet ring cell carcinoma if it's greater than 50%, and it's classified as poorly differentiated. And for the PSO-GI terms, again, we're just tacking over on the term with signet ring cells. So that's our whirlwind overview of the different terms used for primary appendiceal tumors as well as those in the peritoneum. And as you can imagine, this can be confusing when residents are trying to learn this terminology, so we thought it would be helpful to develop an algorithmic approach to diagnosis. So this is kind of a mock-up of our algorithm that we're going to be incorporating into an app. And as we go through this, you will probably notice that there are some oversimplifications, primarily because this is meant for a teaching algorithm. So later in my talk, I'll discuss how we can incorporate some other branch points into here, and what mimics we should be considering and where those would fit into the algorithm. But I'll begin with the basic algorithm that we developed. So on the left side of the algorithm, we have primary appendiceal tumors, and on the right side, we have peritoneal tumors, or clinical pseudomyxoma peritonei. So starting on the appendiceal side of the algorithm, we begin with the assessment of whether or not neoplastic epithelium is present. And if true neoplastic epithelium, and I included the term mucocele, which is better called either inflammatory mucocele or retention cyst, primarily to illustrate that a distended appendix filled with mucin does not necessarily mean mucinous neoplasm, although you definitely want to carefully examine these specimens. Inflammatory mucocele or retention cysts result from obstruction of the appendiceal lumen and accumulation of intraluminal mucin, which can lead to dilation of the appendix, so it can look like a tumor. And in terms of histologic features, you don't have true neoplastic epithelium, and there can be some alterations to the wall, grievances and fibrosis, and some inflammation. And there can be foamy histiocytes. In this case, they're lining the luminal surface, so these should not be misinterpreted as mucinous epithelium. But of course, it is important to examine these specimens carefully, as lamins are more common than mucoceles of the appendix, so these should be entirely submitted to exclude a true neoplasm. Moving on to the side of our algorithm where we do have true neoplastic mucinous epithelium, we now move to our branch point, which involves assessing whether there's a pushing border or infiltrating invasion. And on our pushing border side of the algorithm, we then look at low versus high grade cytology. So the tumors that have true neoplastic epithelium, the pushing border, and low grade cytology are referred to as lamins. So here we can see two examples of lamins. Here we can see columnar cells with basally oriented nuclei, although you can get, in other cases, more fiber accumulated cells. And as you can see here, you can get papillary structures. And at lower power, we would see a smooth border with loss of the limb, appropriate musculars and foci, and you can also see fibrosis in some mucosa. So those are helpful low power clues that you could be dealing with the neoplasm if you have loss of this structure. And I'll discuss later how these can be helpful in differentiating lamins from some units. In terms of staging, AJCC 8th edition actually does not have T1 or T2 for lamins. Instead, we have those that are confined to the submucosa and muscularis propria, staged as in situ lesions. Those that involve the subserosa are T3, and those involving serosal surface are T4A, and those involving adjacent structures are T4B. And this staging has clinical significance. So if the tumors are confined to the muscularis propria, resection with negative margins is typically curative. On the other hand, if an appendiceal surface is involved, for a T4A lesion, disseminated disease can occur. And a recent study showed that about 3 or 4% of patients with acellular mucin on the appendiceal surface had later disseminated disease, and that could even be due to sampling errors, so maybe we had some cellular mucin that was unsampled. Whereas those who have true cellular mucinous deposits have about one-third of them will go on to develop disease. So that's an important thing to assess in lesions. Moving on to lesions that have neoplastic epithelium, a pushing border, and high-grade cytology, we get to Hammond. So these are similar to lamins at low power because of the pushing border, but they then have high-grade cytologic features, which can include nuclear enlargement and rounding, prominent nucleoli, increased mitotic figures, all of which we can see here, as well as loss of polarity, where we have some cells that are basally oriented and some that are more luminally oriented. And you can also get some architectural features, such as the cells piling up. And I don't have this shown here, but I don't have this shown here, but in some cases you can get triple architecture. So for Hammonds, which are relatively rare, it's important to submit the entire appendix for histologic review to rule out focal invasion. Because if you find focal invasion, you're then dealing with a mucinous adenocarcinoma. These lesions are staged as invasive adenocarcinoma as opposed to the staging schema shown with the lamins. And in terms of clinical features, since these are relatively rare, not as much is known about their natural history. They may have an aggressive clinical course, although this could be due to unsampled invasive component. And Raul Gonzalez recently presented a poster at USCAP, which was a median of 3-year follow-up of 19 patients with Hammonds. And he found that 3 of those patients had pseudonephrotic peritoneum and died of the disease. 3 were still alive with pseudonephrotic peritoneum, and the rest were disease. So it can have sort of variable clinical course, and I'm not sure in that study if a couple of the appendices may not have been entirely submitted, that I'm just not sure. But in any case, appropriate treatment for these patients typically consists of resection with negative margins and long-term clinical follow-up, because these can recur. Now let's move to the side of the algorithm where we have true infiltrative invasion. So when we get to this side of the algorithm, we also need to assess whether or not significant cells are present. So if we have neoplastic epithelium, infiltrative invasion, and lack of significant cells, we get to mucinous adenocarcinoma or differentiated. And this type of tumor can have 2 different patterns of invasion. So typically with colorectal carcinoma, you would think about atypical glands with an associated desmoplastic stroma. And that can be seen, but there's also a pattern that's been described in mucinous adenocarcinoma. Actually, it was in one of Dr. Pai's papers of small cellular mucin pool pattern, where you basically have these clusters of high-grade epithelium that are floating in small pools of mucin that are infiltrating the appendiceal wall. And this may not have associated dysplasia. These lack a true signet ring cell component by definition. And mucinous adenocarcinomas typically behave aggressively and often have peritoneal involvement at presentation. Treatment typically involves a right hemicolectomy, primarily to get your lymph nodes, and treatment is otherwise similar to colorectal adenocarcinoma. If instead signet ring cells are present, we then have a mucinous adenocarcinoma with signet ring cells, poorly differentiated or grade 3. The signet ring cells can be seen floating in pools of mucin or infiltrating the appendiceal wall, and they may comprise the entire tumor, or as seen here, you can have a signet ring cell component and also an associated glandular component. If the signet ring cells comprise more than 50% of the tumor, then the correct diagnostic term is mucinous signet ring cell carcinoma. And in terms of management, similar to their grade 2 counterparts, these often have peritoneal involvement at presentation, and treatment is similar to colorectal adenocarcinoma.